I'm Owen Brown, as Colby was saying. I'm a graduate student at the University of Prince Edward Island in Canada, and today I'll be talking about simulating emergency department demand with synthetic data, which in itself is using SAS for health system capacity planning. So just a quick background, I think it's relevant as to where this project takes place, as to what it is. So I'm from the small province of Prince Edward Island, which is right there, quite a ways away from Texas. This work was done on a medium-sized Canadian emergency department, so it's an important factor when understanding the operations and why we did this work. And I've included some pictures I've taken as well as our province. Pretty nice beaches. It does not always look like that, I'll tell you that for sure. So just to give you an overview of the presentation today, we're going to go through the background and context, the purpose of why we did this work, the methodology of how this work was completed, the results, what we're seeing so far, as well as the applications of this work in the future direction. So structured a bit like an academic paper in that way. So a big question is, what is emergency department demand and capacity planning? So we're going to go through this before we get into it too much further. I personally like to think of the emergency department as a sink. The faucet is always on and patients are always coming into the system. This represents the system input. The size of the drain, so the hole at the bottom of the sink, is the throughput. This is the amount of patients that can be put through an emergency department based on the internal resources that exist within. So this is things like physicians, nurses, staffed care spaces, testing facilities, other equipment. At the back of this is the output, so that's the drain that exists beneath the drain that exists beneath the hole. So basically, this is how many things externally outside the system impact emergency department operations. So this is things like how many inpatient beds are in the hospital that patients can be put on towards. Can patients be sent home, and what home care resources are there for them? So capacity planning, all in all, is just a process for determining current and future health service requirements. And the goal with our capacity planning project is to align the resources within the emergency department at a local hospital in Prince Edward Island with the patient volume, arrival frequency, and level of care needed that is required to take care of these patients. So this is the system demand. Effective capacity planning is shown to support smoother patient flow, shorter wait times, and efficient resource use. And patient flow is a term I'll use a few times throughout there, and just to define it, this is the journey of a patient through a healthcare system to get care and then to be discharged or taken to their next step of care. So I got into a little bit of why ED capacity planning matters, but capacity issues, when there's not enough capacity to equate to system demand at the correct time, can contribute to crowding, long wait times, and inefficient throughput. Crowding is just defined as instances where the emergency department does not have enough capacity to take on the amount of patients that is coming. So this can be seen when you see crowds in either the emergency department itself, having care spaces like beds and chairs and hallways needing to be used, it's crowding, as well as in the wait room. You can see crowds where people are waiting to be triaged and then sent into the emergency department itself. These delays in ED care affect experience, patient outcomes, staff workload, and system performance. I'm sure, unfortunately, many of us have been in the emergency department before, whether for ourselves or for a loved one, and we understand that long wait times are not good at all. This can actually contribute to a phenomenon in Canada that we call leaving without being seen. So this is when patients are registered and triaged and make the decision before they see a physician to leave as they don't think they're going to get care that day or in a reasonable amount of time for what they have. There's a lot of reasons that go into this, but the wait time is the major driving factor. This affects patient outcomes in that when patients leave the emergency department, there seems to be a clear increase in morbidity and mortality. As well, within 7 days, these patients typically tend to re-present to the emergency department, so we're likely going to see them again anyway. We're not treating them, we're just delaying them for a future day. As the entry point to the hospital, the emergency department should aim to limit congestion as much as it possibly can externally to the system. So being able to predict demand in the emergency department is essential. So demand varies in a few ways. When we think of demand, we maybe just think of X amount of patients get to the emergency department and that is our demand. But there's more to it than that. The timeliness of when patients arrive. So these patient arrival patterns can vary throughout the day. There's maybe peaks throughout the day in terms of before lunch, after lunch, before dinner. You're seeing patient peaks, ebbs and flows throughout the system. And the system needs to be able to respond to these peaks, not just a flat line. In terms of severity, so represented by the Band-Aid, patients will come in with different severities and different conditions that require different treatments, different amounts of commitment from physicians, resources, and staff care spaces. A patient that is going to a trauma case is going to need far more time from physicians than one that just needs minor treatment, so it's important to distinguish between those. Building on that, our little checklist here is to say that patients will need certain tests like CTs, X-rays, or labs, and some won't. This also heavily contributes to the amount of time a patient will spend in the emergency department and what resources are needed to match that patient. The hospital itself is to say that each hospital is actually itself, in fact, different. So some have X-rays that are located within the department, for example. Some staff according to peaks. So it's important that when we're doing these capacity and demand modeling projects, that we're understanding the emergency department that we are modeling for. So better demand puts matter because planning models rely on realistic assumptions. So it's the garbage in, garbage out principle. We need to make sure that the inputs into any simulation or capacity operation are in fact accurate to the system. So this is addressed in our project by using SAS to generate synthetic patient-level demand data to support a simulation project. So to give you a brief overview of everything we're doing here, is we're using SAS on Demand for academics to generate a synthetic data set. We're then feeding this synthetic data set into an operational emergency department simulation, and then simulating different ways we can staff this emergency department to see how it can best impact how many patients we can get through the system and what is their length of stay. But you might ask yourself, why are we using synthetic data? So why is realistic planning data hard to access? So the data challenge with ED capacity planning is that often the data that researchers need can be difficult and costly to obtain. So typically in other simulation projects, researchers would use historical data sets from a long period of time from their emergency department at patient-level records with their time of arrival, their acuity. For us in Canada, that's measured with the Canadian Triage and Acuity Scale, their demographics, and their care needs. But this patient-level data can be very difficult and costly to obtain, so there needs to be a workaround for it. So if we talk about the privacy and data access limitations, so as we discussed, patient-level data is harder to obtain, but it's easier to obtain summary and aggregate level data, things that are either more easily releasable or that are public in the first place. So access for these can require ethics approvals. Access for patient-level data can require ethics approvals, data release agreements, privacy restrictions. I'm not here to say that these things are not needed at all. It is extremely important to have good ethics processes around your patient-level data. What I am saying is these protections do sometimes slow or limit research work. And if there's a way that we can generate synthetic data sets to get around this, that is only to the benefit of the system and the patient. So our big question here and what I want to get to today is, can we create synthetic patient-level data sets from aggregate-level data that are sufficiently representative to feed into simulation models? I have this big definition of synthetic health data here, but really what I want you to get from this, I won't read it out. Synthetic data is not simply anonymized patient records, but it's using artificial records to preserve meaningful patient patterns. So especially when we talk about demand, we want to preserve things like when patients are arriving and with what their acuity is. These are the two biggest things. We're not trying to reproduce certain individuals, I should note as well. And this is a very good visual for it. So we could say that this is our real world data here. Obviously it's not graphed like this, but our synthetic data isn't attempting to just match it, but produce the similar pattern that we're seeing in the real world. Synthetic data is very useful in healthcare through research, education, clinical trials, operational planning, and more. And I'm sure you hear lots of other people talk about this week. But for operational work, having the synthetic data makes it easier to share data and results in a lower risk manner. So during this project, there was some collaborations with other universities in a more streamlined way because we didn't have to go through the ethics approvals to be able to share our patient-level data with them because all of our patient-level data was completely synthetic. It can also accelerate model developments while you're waiting for patient-level data. So say eventually we did want to feed real historical data into our simulation, we already have it built and validated with synthetic data that's representative of what we're actually going to see. So synthetic data just aims to reproduce these patterns in a way that's useful for planning, simulation, or other project goals. So getting this high-level information in Canada, publicly available operational, aggregate, and summary level data is available in Canada in 3 main steps. So there's the Canadian Institute of Health Information, which is kind of the national jurisdiction. Then there's provincial departments of health that exist within each of our provinces. And then within this as well, there's operational health organizations that do the operations of the healthcare itself. So all of these bodies publish online publicly a lot of aggregate and summary level data that can be used to construct synthetic data sets of patient level records. As well, if we did want the stuff that's not publicly available, it is also much easier to get than the patient level records itself, just in terms of ethics and timelines and cost. In our province of interest, we have a ministerial governance and a provincial health authority which control our health system, and they've been very supportive of this project, but it is still difficult to obtain these patient level records, which is something that I thought that there might be a way around. So now we'll get into the methodology, so the SAS On Demand for Academics portion of this presentation. So a program was created with 4 sections. I like to just break it down more simply like this, in terms of we set the parameters. So we looked at all the publicly available data, we understood what the parameters of what we could see were, and we set them at the beginning of this program. We then generated patient arrivals randomly on hour and on day based on what this data and other literature available in terms of what the patterns of patient presentations would be to our hospitals. We then created patient records from these arrival estimates and assigned characteristics and care needs to these patient profiles. So from just operational and aggregate level data, we were able to reconstruct patient level records that matched this data in an operational way. So when we parameterized our program, we set macro variables just to make it very easy for other people to see what we were doing. So up here we have the start and end date of our simulation. We broke our simulation just for today's presentation into 3 blocks: night, day, and evening. Night, we typically see our lowest number of presentations, day our highest, and evening in the middle. What we're doing now with this work is we actually have 24 of these buckets, 1 for each hour of the day, so you have a much smoother flow over the course of the day, but just for the presentation today, 3 buckets. We say our night is from midnight to 6:59, our day is from 7 to 18:59, and our evening from 19 to 23:59. We then set the minimum and maximum amount of patients that we expect to see during any given hour based on the literature and the values that are publicly available. So from the night in any given hour, we expect to see between 2 and 7 patients. From the day, we expect to see anywhere between 5 and 16. And from the evening, we expect to see anywhere between 4 and 12. So this was designed for easy recalibration for other facilities or even for our own uses. Then within this, we also assign probabilities of patient characteristics. So we use macro variables again to define at the top here acuity, so P underscore for probability, A1 for acuity level 1, 2, 3, 4, and 5. So our CTAS score, 1 is a resuscitation patient, most severe, 5 is a non-urgent patient, least severe, and I'll get into this a little bit more. As well, probability male-female, which is what is reported, and probability age group, which is what is reported. So again, CTAS, I just want to touch on again, is the logic behind patient prioritization in the real world, so it's very important that we get this right. So that's how physicians and nurses will decide who gets treatment next, and it also determines what treatments they will get once they're back there. So we then generated the hourly arrivals. So random arrival counts are generated separately based on arrival periods, so the 3 periods I was talking about, to maintain this diurnal pattern of patient presentations to the ED throughout the day. So what we did is from arrival date start to end date, we then ran month, day, and hour, getting patient arrivals for each hour within each day within each month of the arrival period. So going back up like this. This provides a controlled randomness as hourly arrival generations are aligned with known temporal patterns within the system. The outputs were then stored in separate data sets and combined together before moving into the next step where we completed these individual patient profiles. And here's just the example of the other 2 buckets. It's the exact same pieces of program except with the other macro variables plugged in. We then set up the patient profiles by looping through all the patients arriving in each hour and assigning an ID and a full time of arrival. So for minute and random, we just spread them out randomly across the hour, but still maintaining that hour and daily variation. We then created these patient profiles with the macro variables we had set earlier with the RAND table function to sample acuity, sex, and age group from the predefined probabilities. So recalling our macro variables here and using the random table function with the probabilities that we had set earlier. So acuity came directly from the province of interest, while age and sex probabilities came from national sources to reflect these characteristics. And while age and sex aren't necessarily super critical in our next step where we do operational simulation, it is something that helps create more realistic patient profiles and could be used in future work. The last part of our SAS program here is we do categorical sampling and operational assignments based on CTAS or acuity score. So there's a nice little graphic here to show our acuity score from 1 through 5, resuscitation, emergent, urgent, less urgent, and non-urgent. So condition severity is used to assign patients to their likely pathway of care here. So for example, we can see that if patient acuity is 1, they will always be assigned to trauma care. These resuscitation patients always need trauma care. For 2s, there's a 60% chance they'll need trauma care, or the remainder percentage they'll need base care. So some patients go to trauma care as they've been potentially shot or in a car accident and they are only a level 2, but other patients that have more medical problems like pain and there's no real source of it, they will go to more medical beds, so base ED care. And this is the same for 3, 4, and then 5 is all the minor care, but it's a similar thought with 3 and 4. A similar process is used here for labs and radiology based on literature, and this is what helps guide patients through our operational simulation, which I will discuss very shortly after we get into the results. So what does this synthetic data set look like? I've showed you kind of the program behind it, but what it is a structured synthetic data set that can be formatted at patient level or under different summary formats and used for whatever purpose it may be. I just pulled out this daily summary table just to show what this program was spitting out. So we can see by day and day of week the amount of arrivals, the amount that are male and female, the amount that fall into each acuity bucket, each age bucket, each care bucket, and then how many lab, CT, and X-ray procedures would be needed on this given day. Then, since we're using publicly available data, we need to validate these outputs in a different way than we potentially normally would. So we compare our synthetic outputs against historical summaries and known trends to help validate this work. So this could be things like validating against other publicly available data sets, results from literature and reports, as well as expert consultation from those within emergency departments, or working directly with the entity of interest to get these values. For our simulated work and with our operational model, we're most interested in time of arrival and level of acuity. These are our 2 main variables that control how patients will move through an emergency department system. Now into the application of this, which is my personal favorite part, but we'll show you now. So again, just an overview of what we've done. We've created our synthetic patient data set on SAS On Demand for academics. We then feed it into a hospital operations simulation. So what we've done is we've gone into this hospital, we've gathered their workflows, how many providers there are, how many care spaces there are, how many spaces for testing there are, like CT labs, X-rays, what these waits tend to be, what the process times are, and we've created a hospital operations simulation that is reflective of what is happening in the real world. Then we can trial different operational scenarios. So the hospital wants to know what would happen if they targeted a physician in the morning or an extra physician at night. What if they added another care space or 2? We can then see what these effects on the system would be before the hospital actually has to spend the money and take the risk to implement these things. So for our simulation, we use discrete event simulation, which is just a method of representing and studying the behavior of physical systems that involve entities over time. So when we think of the emergency department, we think of maybe you get there, you're registered and triaged, and there's a bunch of other people there. You wait in the waiting room for a set period of time. You're then assigned a staff care space, which will have a certain quantity of nursing and environmental services and other services around it. A physician will then see you for your initial assessment. You'll then be some type of treatment, testing will be done, maybe a physician follow-up, but there's your care. And then you are dispositioned in some way. You're either discharged home, you're admitted into the hospital, whatever that might be. Obviously, it's a little more complex than that, and our model does reflect this complexity, but this is just a good exercise to get thinking about the hospital and the emergency department as a series of discrete events. So as we were talking earlier about needing accurate inputs, so too does a discrete event simulation model. We could build the most representative, sophisticated discrete event simulation model in the world, and if we feed it patient data that's not representative of the actual demand that it's getting, we will come up with harmful recommendations. If we're feeding a discrete event simulation data information that's showing that our patient peak is at 7 a.m., and we provide recommendations to staff for that, this would obviously be harmful if the peak in reality was at, say, noon. So this is something to just take into consideration, is that we need these accurate demand inputs that we've created through SAS to make our simulation model more applicable for decision makers. So in other ED evaluations, synthetic data has been exported and used as arrival information. So the timing and patient characteristics that we pulled from SAS are then the basis for the routing and the service requirements that exist within the emergency department. So different arrival times can change queue lengths. So say 10 patients arrive at 10 a.m. and then one more arrives at 11. This patient at 11 a.m. is now stuck in a queue of 10 patients and will likely wait longer for their care as if 2 patients arrived during 10 a.m. So these arrival times are not just dependent on yourself, but dependent on the system as a whole, which our model reflects. Different acuity levels, it's the same principle. If lots of patients that only require minor care are ahead of you for minor care, you're likely going to wait longer for this minor care than as if these patients didn't exist. We can also, in our model, change the synthetic inputs that we're feeding in through SAS to model future states. So say that we predict that there's a 50,000 population increase around the emergency department in the next 3 years. We can then increase the amount of synthetic input we're putting into the system to test our sensitivity to see how many more patients this hospital could take with current resources and what potentially we would need to match this future demand so we can start planning ahead of time. Our discrete event simulation is just built like a pathway. So patients will originate at the patient entry and start, and you'll see basically a little bubble go through the system. There'll be different colors depending on their acuity, just so we can track them going through the system. But they'll go through the entry start where they're assigned all their characteristics. They'll then go through an initial assessment process where they wait in a waiting room and then are sent to trauma, regular care, or minor care. As well as this, we have a leaving without being seen mechanism that we've recently implemented that sees how long a patient waits for and provides a likelihood of this patient leaving based on their acuity and the time that they've waited. We have no level 1 patients leaving, but say you're a level 2 patient that's quite sick, you're far less likely to leave than a level 5 patient that potentially just hurt their hand. They're more likely to go home in a timelier manner, and our model reflects this. We then go on to testing and follow-up, where patients go through a likelihood of being assigned a test and a physician needing follow-up care, and then a disposition and end block. So we track all the data for that patient, we pull all this out, and then we analyze it. So as I was talking about with our scenario testing, after validating this representative model, we can then apply it to inform these real-world operations. So for our work, after our base model was created, we did 8 different scenarios using different quantities of operational care spaces and physician shifts just to compare them to each other and see how they would interact. So our changes to the system were 1 care space, 1 staff care space, 2 staff care spaces, a physician targeted in the morning, and a physician targeted at night. We then, in combinations of these as well, I should say, so we would add a daytime physician with this 1 bed, or a day with 2, a night with 1, and a night with 2. So the raw patient data was then exported. We simulated for a period of 5 years and then exported this back into SAS. To analyze this data, we did a mixed model regression as well as a ANOVA, or analysis of variance. So our mixed model regression was aimed to estimate the association between the fixed and random predictors on ED length of stay. So our fixed predictors are the physicians and the staff care spaces that we've talked about to date. The random predictors are everything else that impacts the emergency department flow, which is everything else this presentation has touched on. We can then see exactly exactly quantify the amount of effect on length of stay that comes from these additional physicians or staff care spaces in the system. Our analysis of variance is used to compare these scenarios directly to each other, so this is more applicable for the hospital. We can see if there's actually a significant difference in adding a care space or a morning physician or a night physician or even 2, or combining them together. We can see where the most value would be in terms of reducing length of stay and increasing throughput for the hospital before they ever have to do it in real life. Now, these results are currently being processed for inclusion in a master's thesis work, but what I can tell you is that playing around with the model, we have found that there are very targeted times throughout the day according to the patient flow where you can add in physicians just for a few hours and extract just as much benefit as if you almost added a full other shift in. So these are some insights that hospitals could use in order to staff more effectively. And obviously, there are some issues with only smaller physician shifts, but this is only an operational thing, not actually to use it in the real world. So what does this all mean? So synthetic data from summary-level data sources can help support simulation and capacity planning by providing these representative demand inputs. Our methodology here supports realistic modeling while also reducing privacy risks. And the project itself draws a bridge between data protection by not having to take these patient-level data from the system and use them, with the operational decision-making of showing operators what scenarios can best help their hospital. So in terms of future direction, there are a few limitations in generating the synthetic data. So we do know that patient characteristics are linked to each other within, so say, for example, an older patient is more likely to have a higher severity and more likely to require tests such as CT and X-ray. So our model currently doesn't reflect that, but when we're putting patients through into the system, we're only really looking at acuity as the decision factor in this. So for our work, it's not so much of a limitation, but for future work, it could be. We also want to test this model on other care site types outside of a medium-sized Canadian ED. As well, incorporating adverse surge events, which are times where an emergency department experiences a surge in patients from an event happening outside, maybe some sort of mass casualty event where tons of patients at high severity levels come in. We need our operation to be able to understand how emergency departments can best respond to instances like this. Overall, and as well, I do want to bring my learnings from Innovate back to this project. This has been a really good day and a half of learning and something that I think has really built on my ability with SAS. So that's another part for this project. But overall, as a whole, we do want to expand the simulation model to include inpatient beds and downstream resources. So we're not just looking at the size of the drain hole, but we're looking as well as the pipe that controls how many patients can get through the system as a whole. So thank you very much for your time. I know there's a lot of other presentations going on today, so I really appreciate your 20-25 minutes with me today. So thank you very much.